Hello, my name is Matthew McCoyd. I'm a neurologist. I work at Loyola Medical Center, and I run the Neurology Residency Training Program. What I'm going to do over the next few minutes and the next few modules is review a few topics in neurology, specifically vascular disorders such as stroke and transient ischemic attacks, as well as seizures. What we are going to cover are a few topics I think will be high yield for the examination you're about to take. We're going to focus on some really common stroke disorders and some very common stroke mimics, as well as some seizure disorders. Just in starting, before I get into some of the nuts and bolts of those specific topics, I just want to take a few minutes to talk about the approach to neurology and how I think through cases as a neurologist. So for me, on your test, obviously there's going to be a great deal of information mixed in together. But when it comes to the neurology questions on the test, and then for me, for the neurology questions that come up in our clinic, what I typically start with is number one, do I think that there's a neurologic problem? Which isn't always an easy differentiation. But do I think the individual has a problem somewhere in the nervous system? If I do think there's a neurologic disorder, in neurology, disorders tend to fall into one of two camps. There are disorders of the central nervous system, which is really the brain, brainstem, and spinal cord. And there's disorders of the peripheral nervous system, which for all of its complexity is only the nerve, the neuromuscular junction, and the muscle. It is very rare in neurology that diseases will affect more than one system. So if I can make that initial determination, I think there's a neurologic disorder, and then the second determination is its central or peripheral nervous system, I'm a long way home towards my diagnosis. Things that I find to be helpful in that decision about central versus peripheral nervous system. Central nervous system is the brain. And so level of alertness or mental status are significant factors for the central nervous system. Peripheral nervous system disorders will not give you cortical findings like aphasia or neglect. They will not give you altered mental status. So if a patient's having difficulty with level of alertness, with language production, I know there must be a problem with the brain and the central nervous system. I can also find on the exam or on the test or in my clinic, upper motor neuron findings. So upper motor neuron findings are things that have damaged the cortical spinal tract, which are your motor pathways, specific to the brain and spinal cord. And a patient with an upper motor neuron finding will have some weakness, but specifically hyperreflexia, usually pathologic hyperreflexia, including a Babinski or upgoing toe. If present, means that there must be a problem in the central nervous system and specific to the cortical spinal tract, as well as increased tone. So any patient who is hyperreflexic, I immediately think there is very likely or must be a central nervous system disorder. The other thing I find to be extremely helpful in neurology for central versus peripheral is the sensory level. If a patient says they are numb in their feet or their legs, how high up does that numbness go? Any patient who gets numb to the abdomen, to the chest, or even to the top of the head, developing a sensory level, almost must have a spinal cord lesion. There are very few things that cause numbness in the torso, particularly symmetric or sensory level, besides spinal cord disorders. And the last group that I find that can be helpful for central nervous system are most movement disorders. Patients with Parkinson's disease, for example, or hemiballistic movements, or Huntington's-like features, are typically central nervous system. I can contrast that with peripheral nervous system. The peripheral nervous system is the nerve, the neuromuscular junction, and the muscle. Patients with problems of the nerve are typically weak and or numb, often in the distribution of a nerve root or the nerve itself. Patients with neuromuscular junction disorders typically have fluctuating symptoms. They will have intermittent double vision, intermittent ptosis, symptoms that come and go over the course of the day, usually being worse late in the day. And patients with muscle weakness usually have proximal or symmetric muscle weakness, but no other findings. They have no issues with sensation. Their reflexes are typically normal. They are just weak. I find in my experience within the residency program and working with medical students, some things I find to be less helpful are things like cranial nerve abnormalities. Patients who have a cranial nerve finding, well, I know it's a neurologic disorder, it doesn't help me much with if it's inside the brainstem or central nervous system or in the nerve itself, which can be part of the peripheral nervous system. I have many medical students tell me if both feet are numb, that's probably peripheral nervous system. And I find symmetry doesn't help me all that much because spinal cord symptoms can do that as well. Romberg sign, I find to be very helpful for determining a neurologic disorder, but only tells me there's a problem with balance systems. It doesn't tell me if it's peripheral or central. And it can be a peripheral neuropathy, why the individual is off balance. It could be a spinal cord disorder. It could be a cerebellar disorder. I know something's wrong, but I'm not sure where it's located. That's also true for vibratory sense. That could be from a peripheral neuropathy, or it could be from a spinal cord disorder. The reason I like to start with this slide, though it may not help you with the nuts and bolts of a specific question, is it gives me a bit of a basis to work towards an answer. Is there a neurologic disorder? If there is one, is it in the central or the peripheral nervous system? Because it is rare in neurology that diseases will affect both. Central nervous system, altered mental status, upper motor neuron findings, sensory levels as really being the most helpful, telling me I need to do investigations into brain and spinal cord health. If I think there is a central nervous system disorder, this is the mnemonic I like to use, or simple. Is there a structural disorder? Is there something wrong with the structure of the brain or the spinal cord? Individuals with stroke, for example, I've damaged the brain. There's a structural abnormality with the brain, and their findings will reflect whatever I injured. Is there an infectious or inflammatory process? Does the individual have altered mental status because they have meningitis or encephalitis? Is there a diffuse inflammatory process like multiple sclerosis potentially could cause that may cause central nervous system findings? Is the issue really due to a medication or a metabolic derangement? Altered mental status due to hypoglycemia or hypernatremia, or they're on anti-seizure medications or antibiotics that may affect their level of alertness? Is it a disorder that comes and goes? Things like seizures, for example, that are paroxysmal. The patient's normal in between events. Then the family comes and says they're transiently altered for short periods of time. Could that potentially be a seizure, migraine, or maybe even a cardiac abnormality? The last two groups are neurodegenerative disorders. So someone comes in for progressive neurologic decline. Could this represent an Alzheimer's or some other dementing process? Or, which I would not expect to come up on your test, but in neurology in general, is it an early onset neurodegenerative disorder, something more likely to affect someone earlier in life, such as in their pediatric, teenage, or 20s or 30s, something I wouldn't anticipate being covered on your upcoming test. But for me, this mnemonic tends to work well when I'm approaching a patient, either on a test question or in the clinic or in the hospital. I think they have a neurologic disorder. I think it's something affecting brain or spinal cord. Is it a structural abnormality, which is often a major neurologic emergency? Is it an infectious process or inflammatory process I need to act on quickly? Did I cause this problem with medications or metabolic side effects? Is it something that comes and goes, like a seizure, where I'm going to need some testing? Or is this a late life neurologic decline that I simply need to manage but not emergently intervene with? And I found this to be extremely helpful in my thought process towards cases.